Hello class, welcome to Chapter 12, Shock. After students complete this chapter and the related coursework, they will have an understanding of the different types and causes of shock, the process of perfusion, the signs and symptoms associated with shock, application of the assessment process with the shock patient, and the general and specific emergency medical care provided to patients experiencing shock. Introduction. In this chapter, shock, or hypoperfusion, describes a state of collapse and failure of the cardiovascular system. In the early stages of shock, the body will attempt to compensate by maintaining hemostasis, a balance of all the systems in the body. As shock progresses, however, blood circulation slows and eventually ceases. Shock can occur because of medical or traumatic events, such as heart attack, severe allergic reactions, motor vehicle crash, or gunshot wounds. EMTs respond to different types of emergencies to provide care and transportation. They must be constantly alert to the signs and symptoms of shock. Pathophysiology. Perfusion is a circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs. The body is perfused via the circulatory system. The circulatory system is a complex arrangement of connected tubes including arteries, arteries, capillaries, venules, and veins. There are two circuits in the body, the systemic circulation in the body and the pulmonary circulation in the lungs. The systemic circulation carries oxygen-rich blood from the left ventricle through the body and back to the right atrium. The systemic circulation, as blood passes through the tissues and organs, it delivers oxygen and nutrients. Adequate perfusion is also important for the removal of waste products, such as carbon dioxide, which is picked up from the cells as the blood circulates through the organs and returns to the heart and lungs. Organs, tissues, and cells must have adequate oxygenation or they may die. Each time you take a breath, the alveoli, which are microscopic, thin-walled air sacs, receive a supply of oxygen-rich air. Oxygen diffuses through the walls of the alveoli into the bloodstream and attaches to hemoglobin circulating on red blood cells. If oxygenated blood is not properly circulated, cell death may occur. Diffusion is a passive process in which molecules move from an area with higher concentration of molecules to an area of lower concentration. Oxygen molecules move from the alveoli into the blood. Carbon dioxide moves out of the blood into the alveoli. Whereas the majority of oxygen is carried to the tissues attached to hemoglobin, carbon dioxide can be transported in the blood from the tissues back to the lungs in three ways: dissolved in the plasma, combined with water in the form of bicarbonate, and attached to hemoglobin. Carbon dioxide waste products released from the cells can combine with water in the bloodstream to form bicarbonate. Bicarbonate concentrations become higher as more carbon dioxide is produced and the blood moves back toward the lungs. Once it reaches the lungs, the bicarbonate breaks back down into carbon dioxide and water, and the carbon dioxide is exhaled. In the cases of poor perfusion or shock, the transportation of carbon dioxide out of the tissues will become impaired, resulting in a dangerous buildup of waste products, which may cause cellular death. Shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation. Like internal bleeding, shock is an unseen life threat caused by a medical disorder or traumatic injury. To protect vital organs, the body directs blood flow from organs that are more tolerant of low flow, such as the skin and intestines, to organs that cannot tolerate low blood flow, such as the heart, brain, and lungs. If the conditions causing shock are not promptly addressed, death may soon occur. By recognizing the signs and symptoms of shock early, you can minimize organ damage and save lives. Shock is life-threatening and requires immediate recognition and rapid transport. The cardiovascular system consists of three parts: a pump, the heart, a set of pipes, blood vessels or arteries that act as the container, and the contents of the container, the blood. The figure on the slide illustrates the cardiovascular system. These three parts can be referred to as the perfusion triangle. When a patient is in shock, one or more of these three parts is not working properly. Blood pressure is the pressure of blood within the vessels at any moment in time. Systolic pressure is the peak arterial pressure or pressure generated every time the heart contracts. Diastolic pressure is the pressure maintained within the arteries while the heart rests between heartbeats. Pulse pressure is the difference between the systolic and diastolic pressures. Systolic pressure minus diastolic pressure equals pulse pressure. It signifies the amount of force the heart generates with each contraction. A pulse pressure less than 25 may be seen in patients with shock. Blood flow through the capillary beds is regulated by the capillary sphincters, circular muscular walls that constrict and dilate. These sphincters are under the control of the autonomic nervous system, which regulates involuntary functions such as sweating and digestion. Capillary sphincters also respond to other stimuli such as heat, cold, the need for oxygen, and the need for waste removal. Keep in mind that under normal circumstances, not all cells have the same needs at the same time. The stomach and intestines have a high need for blood flow during digestion. Perfusion requires more than just having a working cardiovascular system. It also requires adequate oxygen exchange in the lungs, adequate nutrients in the form of glucose in the blood, and adequate waste removal primarily through the lungs. Mechanisms are in place to help support the respiratory and cardiovascular systems when the need for perfusion of vital organs is increased. These mechanisms include the autonomic nervous system and hormones. They are triggered when the body senses that the pressure in the system is falling. The sympathetic side of the autonomic nervous system, which is responsible for the fight or flight response, will assume more control of the body's functions during a state of shock. This response by the autonomic nervous system causes the release of hormones such as epinephrine and norepinephrine. Hormones cause an increase in heart rate and in the strength of cardiac contractions, and vasoconstriction in non-essential areas, primarily in the skin and gastrointestinal tract. Peripheral vasoconstriction. Together, these actions are designed to maintain pressure in the system and, as a result, sustain perfusion of all vital organs. The autonomic nervous system and hormones respond within seconds. It is this response that causes all the signs and symptoms of shock in a patient. Causes of shock. Shock can result from many conditions, including bleeding, respiratory failure, acute allergic reactions, and overwhelming infection. In all cases, the damage occurs because of insufficient perfusion of organs and tissues. Pump failure is caused by heart attack, trauma to the heart, or obstructive causes. Types of this kind of shock. Cardiogenic shock, obstructive shock, which can be tension pneumothorax, cardiac tamponade, or a pulmonary embolism. Poor vessel function can be caused by infection, drug overdose narcotic, spinal cord injury, and anaphylaxis. These types of shock are distributive shock, septic shock, neurogenic shock, anaphylactic shock, and psychogenic shock. Low fluid volume can be caused by trauma to vessels or tissues. Fluid loss from the GI tract from vomiting or diarrhea can also lower the fluid component of the blood. These types of shock are hypovolemic shock, hemorrhagic shock, and non-hemorrhagic shock. The illustration on this slide shows the three basic causes of shock and impaired tissue perfusion. A is pump failure, B is low fluid volume, and C is poor vessel function. The table on this slide lists the types of shock resulting from three basic causes. Cardiogenic shock. Cardiogenic shock is caused by inadequate function of the heart or pump failure. A major effect is the backup of blood into the lungs. The resulting backup of pulmonary fluid is called pulmonary edema. Edema is the presence of abnormally large amounts of fluid between the cells in the body tissues, causing swelling of the affected area. Pulmonary edema leads to impaired respiration, which may be manifested by an increased respiratory rate and/or abnormal lung sounds. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. Cardiac output is the volume of blood that the heart can pump per minute, and it is dependent upon several factors. The heart must have adequate strength, which is largely determined by the ability of the heart muscle to contract. The heart must receive adequate blood to pump. The resistance to flow in the peripheral circulation must be adequate. Obstructive shock is caused by a mechanical obstruction that prevents an adequate volume of blood from filling the heart chambers. Three of the most common examples are cardiac tamponade, tension pneumothorax, and pulmonary embolism. Cardiac tamponade or pericardial tamponade, a collection of fluid between the pericardial sac and the myocardium, is called a pericardial infusion. If the infusion becomes large enough, it can prevent the ventricles from filling with blood, a condition called cardiac tamponade. It is caused by blunt or penetrating trauma that causes hemorrhage around the heart. Cardiac tamponade occurs when blood leaks into the space between the tough fibrous membrane known as the pericardium and the outer walls of the heart, an area called the pericardial sac. As more blood or fluid accumulates in the confined space, the outer walls of the heart become compressed. The accumulated blood or fluid in the pericardial space eventually exerts pressure back onto the outer walls of the heart, compressing the walls of the heart and preventing the heart from completely refilling with blood. Continued pressure within the pericardial sac obstructs the flow of blood into the heart, resulting in decreased outflow from the heart. Signs and symptoms of cardiac tamponade are referred to as the Beck triad: the presence of jugular vein distension, muffled heart sounds, and narrowing pulse pressure, where the systolic and diastolic blood pressures start to merge. Tension pneumothorax. It is caused by damage to lung tissue. The damage allows air normally held within the lung to escape into the chest cavity. The lung collapses, and if the pneumothorax is left untreated, air will accumulate in the chest cavity and apply pressure to the organs, including the heart and great vessels. Pulmonary embolism, a blood clot that occurs in the pulmonary circulation that blocks the flow of blood through the pulmonary vessels. When a massive pulmonary embolism occurs, it can prevent blood from being pumped from the right side of the heart to the left, resulting in complete backup of blood in the right ventricle and leading to catastrophic obstructive shock and complete pump failure. Distributive shock results when there is widespread dilation of small areoles, small venules, or both. The circulating blood volume pools in the expanded vascular beds and tissue perfusion decreases. Septic shock occurs as a result of severe infections, usually bacterial, in which toxins are generated by the bacteria or by infected body tissues. The toxins damage the vessel walls, causing increased cellular permeability. The vessel walls leak and are unable to contract well. Widespread dilation of vessels in combination with plasma loss through the injured vessel walls results in shock. Septic shock is a complex problem. There is an insufficient volume of fluid in the container because much of the plasma has leaked out of the vascular system. Hypovolemia. The fluid that has leaked out often collects in the respiratory system, interfering with respiration. The vasodilation leads to a larger than normal vascular bed to contain the smaller than normal volume of intervascular fluid. Neurogenic shock is usually the result of high spinal cord injury. Causes include brain conditions, tumors, pressure on the spinal cord, and spinal bifida. In neurogenic shock, the muscles in the walls of the blood vessels are cut off from the sympathetic nervous system and nerve impulses that cause them to contract. All vessels below the level of the spinal injury dilate widely, increasing the size and capacity of the vascular system and causing blood to pool. The available 6 liters of blood in the body can no longer fill the enlarged vascular system. Even if there is no blood or fluid loss, perfusion of the organs and tissues becomes inadequate and shock occurs. Signs of this type of shock are the absence of sweating below the level of injury, normal or low heart rate in presence of hypertension, and normal warm skin. Anaphylactic shock. Anaphylaxis or anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. Sensitization means becoming sensitive to a substance that did not initially cause a reaction. Each subsequent exposure after sensitization tends to produce a more severe reaction. 4 categories of exposure include injections, such as tetanus antitoxin or penicillin, stings from wasps, bees, hornets, or ants, ingestion of food, such as fish, shellfish, nuts, eggs, or medication, inhalation of dust, pollen, or mold. Anaphylactic reactions can develop within minutes or even seconds after contact with a substance. There may also be a second phase reaction that occurs 1 to 8 hours after the initial reaction. The signs are very distinct and not seen with other forms of shock. Note that cyanosis, blue discoloration of the skin, is a late sign of anaphylactic shock. The combination of poor oxygenation and poor perfusion in anaphylactic shock may easily prove fatal. The table on this slide lists the signs and symptoms of anaphylactic shock. Psychogenic shock. A patient in psychogenic shock has had a sudden reaction of the nervous system that produces a temporary, generalized vascular dilation resulting in fainting or syncope. The fainting episode is temporary and the patient rouses soon after. Syncope occurs when blood pools in dilated vessels, reducing the blood supply to the brain. As a result, the brain ceases to function normally and the patient faints. It is important to realize that some of the causes of syncope are of a serious nature, but others are not. The life-threatening causes include irregular heartbeat and brain aneurysm. The non-life-threatening events may include recipient of bad news or experiencing fear or unpleasant sights, like the sight of blood. Hypovolemic shock. Hypovolemic shock is a result of an inadequate amount of fluid or volume in the circulatory system. There are hemorrhagic causes and non-hemorrhagic causes. Injuries involving bleeding may result in a hemorrhagic shock, while vomiting and diarrhea may result in non-hemorrhagic hypovolemic shock. Hypovolemic shock also occurs with severe thermal burns. Intravascular plasma is lost, and plasma leaks from the circulatory system into the burned tissues that lie adjacent to the injury. Dehydration, the loss of water or fluid from body tissues, can cause or aggravate shock. Fluid loss may be a result of severe vomiting and/or diarrhea. Respiratory insufficiency. A patient with a severe chest injury, such as flail chest or obstruction to the airway, may be unable to breathe in an adequate amount of oxygen. This affects the ventilation process of respiration because not enough oxygen can be inspired to meet the metabolic demand. An insufficient concentration of oxygen in the blood can produce a life-threatening situation as rapidly as vascular causes of shock. Anemia is an abnormally low number of red blood cells. Anemia may be the result of either chronic or acute bleeding, a deficiency in certain vitamins or minerals, or an underlying disease process. Tissues may become hypoxic because the blood is unable to deliver adequate amounts of oxygen to the tissues, even though the available hemoglobin is fully saturated with oxygen and the lungs are delivering enough oxygen to the blood. Certain types of poisoning may also affect the ability of cells to metabolize or carry oxygen. Carbon monoxide poisoning and cyanide poisoning. The progression of shock. The stages in the progression of shock are: Stage 1. Compensated shock. In the early stages of shock, the body can still compensate for blood loss. The signs and symptoms are aggression, anxiety, restlessness, feeling of impending doom, altered mental status, weak, rapid, thready, or absent pulse, clammy, pale, cool, moist skin, pallor with cyanosis around the lips, shallow, rapid breathing, air hunger, shortness of breath, especially if there is a chest injury, nausea or vomiting, capillary refill of longer than 2 seconds in infants and children, marked thirst, narrowing pulse pressure. Stage 2. Decompensated shock. The late stage when blood pressure is falling. Signs and symptoms: falling blood pressure, systolic blood pressure of 90 or lower in an adult, labored or irregular breathing, ashen, molted or cyanotic skin, thready or absent peripheral pulses, dull eyes, dilated pupils, poor urinary output. Stage 3 is when shock has progressed too far. It is irreversible, and there's no way to assess when the patient has reached this point. It is imperative to recognize and treat shock early, well before the patient transitions into the decompensated phase. The table on this slide lists the signs and symptoms of compensated and decompensated shock. Blood pressure may be the last measurable factor to change in shock. When a drop in blood pressure is evident, shock is well developed. This is particularly true in infants and children, who can maintain their blood pressure until they have blood loss that is more than half their blood volume. By the time the blood pressure drops in infants and children who are in shock, they are close to death. Expect shock in many emergency medical situations. Also expect shock if a patient has any one of the following conditions: multiple severe fractures, abdominal or chest injury, spinal injury, a severe infection, a major heart attack, or anaphylaxis. Patient assessment for shock. Scene size up. Scene safety. As you approach the scene, be alert to potential hazards to your safety. If this is a trauma scene or bleeding is suspected, put on gloves and eye protection at a minimum. Put several pairs of gloves in your pocket for easy access in case your gloves tear or there are multiple patients with bleeding. In incidents involving violence, such as assaults or gunshot wounds, make sure that police are on scene. Mechanism of injury and nature of illness. Observe the scene and patient for clues to determine the nature of illness or the mechanism of injury. This can help you anticipate the potential for development of shock. Primary assessment. The primary assessment for a patient with suspected shock should include a rapid exam to determine level of consciousness, identify and manage life-threatening conditions as they are found, determine priority of the patient and transport. A patient with massive hemorrhage may require a tourniquet or direct pressure dressing when tourniquets are not feasible or available before the airway is opened. If the patient has life-threatening external bleeding, it should be addressed first, even before airway and breathing. Then the ABCs should be assessed and treated, and treatments for shock provided. Provide high-flow oxygen to assist in perfusion of damaged tissues. If the patients have sign of hypoperfusion, treat aggressively and provide rapid transport to the hospital. Request advanced life support, ALS, as necessary to assist with more aggressive shock management. Form a general impression. This will help you develop an early sense of urgency for care of a patient who appears sick. Determine the need for manual spinal stabilization and access the patient's level of consciousness using the AVPU scale. A patient who has an altered level of consciousness, LOC, may need emergency airway management. If the patient is awake and alert, determine a chief complaint. Airway and breathing. Assess the airway to ensure it is patent. Quickly assess breathing. Observe the patient for signs of accessory muscle use, such as the muscles of the neck, intercostal retractions, and abdominal use of abdominal muscles. An increased respiratory rate is often an early sign of impending shock. Assess for wheezes or abnormal breathing sounds. Administer high-flow oxygen or, if needed, assist respirations with a BVM. Circulation. Assessing the patient's circulation status can reveal important clues regarding the presence of shock. Check for distal pulse. If there is none, check for central pulses. Determine if the pulse is fast, slow, weak, strong, or altogether absent. A rapid pulse suggests compensated shock. In shock or compensated shock, the skin may be cool, clammy, or ashen. If the patient has no pulse and is not breathing, immediately begin cardiopulmonary resuscitation, CPR. Transport decision. Assess for and identify any life-threatening bleeding in trauma patients. If serious bleeding is discovered, treat it at once. You must also quickly assess skin temperature, condition, and color, and check for capillary refill time. Determine whether the patient should be treated as high priority, whether ALS is needed, and which facility to transport to. Trauma patients with shock or a suspicious MBOI generally should go to a trauma center. History taking. After life threats have been managed, determine the chief complaint and obtain a sample history. Secondary assessment. Physical examinations. The secondary assessment begins by repeating the primary assessment, followed by a focused assessment. Perform a secondary assessment of the entire body if your patient is a trauma patient with significant mechanism of injury or multiple injuries. Your patient gives you a poor initial general impression. You found problems in the primary assessment. Your patient has a medical problem but is not responsive. Your patient has problems that were not noted in the primary assessment. These assessments should be formed quickly but thoroughly to ensure that you do not miss any significant or life-threatening problems or delay needed care. If your patient has only a simple mechanism of injury, such as a twisted ankle, focus your examination on that specific area. Whether your examination is of the entire body or a specific area, if a life-threatening problem is found, treat it immediately. Vital signs. Obtain a complete set of baseline vital signs. If your patient's condition is unstable or could become unstable, reassess vital signs every 5 minutes. If the patient is in stable condition, reassess vital signs every 10 to 15 minutes. Monitoring devices. Use monitoring devices to quantify the patient's oxygenation and circulatory status. Use a non-invasive technique to monitor blood pressure and a pulse oximeter to evaluate the effectiveness of oxygenation. Reassessment. Reassess the patient's vital signs, interventions, chief complaint, ABCs, and mental status. Determine what interventions are needed for your patient based on the assessment findings. Focus on supporting the cardiovascular system. Treat for shock early and aggressively by providing oxygen and keeping the patient warm. Emergency medical care for shock. You must begin immediate treatment for shock as soon as you realize that the condition may exist. Follow standard precautions. Control all obvious external bleeding. Place dry, sterile dressings over the bleeding sites and secure with bandages. If direct pressure is not rapidly successful in the control of bleeding from an extremity, apply a tourniquet proximal to the bleeding site according to the local protocol. Make sure the patient has an open airway. Maintain manual inline stabilization if necessary, and check for breathing and pulse. Comfort, calm, and reassure the patient with maintaining the patient in the supine position. Never allow patients to eat or drink anything prior to being evaluated by a physician. If spinal immobilization is indicated, splint the patient on a backboard. Remember that inadequate ventilation may be a major factor in the development of shock. Always provide oxygen, assist with ventilations, and use airway control adjuncts as needed, and continue to monitor the patient's breathing. To prevent the loss of body heat, place blankets under and over the patient, but try to help the patient maintain a normal body temperature. Transport the patient and treat additional injuries en route. Consider rendezvous with ALS if possible, and consider aeromedical transport. Do not give the patient anything by mouth, no matter how urgently you are asked. To relieve the intense thirst that often accompanies shock, give the patient a moistened piece of gauze to chew or suck. Accurately record the patient's vital signs approximately every 5 minutes throughout treatment and transport. Table 12.4 lists the general supportive measures for the major types of shock. Treating cardiogenic shock. The patient who is in shock as a result of a heart attack simply cannot generate the necessary power to pump blood throughout the circulatory system. Chronic lung disease will aggravate cardiogenic shock. The patient is often able to breathe better in a sitting or semi-sitting position. Usually, patients with cardiogenic shock do not have any injury, but they may be having chest pain. The patient may have taken nitroglycerin before EMS arrives and may want to take more. Patients in cardiogenic shock should not receive nitroglycerin. By definition, they are hypotensive. Other signs and symptoms include weak, irregular pulse, cyanosis around the lips and underneath the fingernails, anxiety, and nausea. Place the patient in a position that eases breathing as you give high-flow oxygen. Assist ventilations as necessary and have suction nearby in case the patient vomits. Provide prompt transport. If ALS is not already on the scene, consider a rendezvous en route to the hospital if available. Provide calm reassurance to the patient who has had a suspected heart attack. Treating obstructive shock. For cardiac tamponade, increasing cardiac output should be the priority in treating cardiac tamponade. Apply high-flow oxygen. Surgery is the only definitive treatment. Pericardial centesis involves penetrating the pericardium with a needle to withdraw the accumulated blood from the pericardial sac. This procedure is an advanced skill and is rarely performed in the field. For tension pneumothorax, administer high-flow oxygen via non-rebreather mask early to prevent hypoxia. Usually the only action that can prevent eventual death from a tension pneumothorax is the decompression of the injured side of the chest, relieving the pressure in the chest and allowing the heart to expand fully again. Chest decompression is an ALS skill. Ask for ALS assistance early in the call if available. However, do not delay transport waiting for the arrival of ALS. Treating septic shock. The proper treatment of septic shock requires complex hospital management, including administration of antibiotics. Use appropriate standard precautions and transport as promptly as possible. Administer high-flow oxygen during transport. Ventilatory support may be necessary to maintain adequate tidal volume. Use blankets to conserve body heat. Notify a specialist sepsis team if available to meet the patient in the ED. Sepsis teams can decrease the amount of time spent in identification of the infectious agent and initiation of the adequate treatment, thereby decreasing the mortality from septic shock. Treating neurogenic shock. For the spinal cord injury patient, use a combination of all known supportive measures. The patient who has sustained this kind of injury usually will require hospitalization for a long time. Emergency treatment must be directed at obtaining and maintaining a proper airway, providing spinal immobilization, assisting inadequate breathing as needed, conserving body heat, ensuring the most effective circulation possible, keep the patient as warm as possible with blankets, transport the patient promptly to a facility capable of managing spinal injuries. Treating anaphylactic shock. The only really effective treatment for severe acute allergic reaction is to administer epinephrine by way of intramuscular injection. A patient who is aware of having a specific sensitivity may carry a kit containing epinephrine. If he or she is unable to inject the medication, you may have to do so if you are allowed by local protocol. If the patient's signs and symptoms reoccur or the patient's condition deteriorates, consult medical control for authorization to administer a repeat injection if available. A patient with anaphylaxis requires immediate transport. Additional emergency care includes high-flow oxygen, 10 to 15 liters per minute via a non-rebreather mask. Assist ventilations with a BVM if necessary. Try to find out what agent caused the reaction and how it was received. Keep in mind that a mild reaction may worsen suddenly over time. Because of potential for airway compromise, consider requesting ALS backup if available. Treating psychogenic shock. In an uncomplicated case of fainting, once the patient collapses and becomes supine, circulation to the brain is restored, and with it a normal state of functioning. Psychogenic shock can worsen other types of shock. If it appears the patient fell as a result of psychogenic shock, check for injuries, especially in older patients. If a patient reports not being able to walk after a fall, thought to be related to psychogenic shock, you should suspect another problem such as a head injury. Transport the patient promptly. It is not safe to assume based on EMT assessment that any fainting was caused by psychogenic shock alone. All patients with loss of consciousness should be transported to the ED for evaluation even if they appear normal once you arrive on scene. Record your initial observations and try to learn from bystanders whether the patient complained of anything and how long he or she was unconscious. Treating hypovolemic shock. Control all obvious external bleeding. The best initial method to control external bleeding is direct pressure. If bleeding is not controlled with direct pressure, consider using a tourniquet. Handle the patient gently and keep him or her warm. Recognize internal bleeding and provide aggressive general support. Secure and maintain an airway and provide respiratory support, including supplemental oxygen and, if needed, assisted ventilations. Watch to ensure the patient does not aspirate blood or vomitus. Transport the patient as rapidly as possible to the ED. Treating respiratory insufficiency. Immediately secure and maintain the airway. Clear the mouth and throat of any obstructions, including mucus, vomitus, and foreign material. If necessary, provide ventilations with a BVM. Administer supplemental oxygen and transport the patient promptly. Treating shock in older patients. The EMT must use caution when caring for older patients. Older patients generally have more serious complications than younger patients. Although illness is a common complaint among older patients, understand that it is not just part of aging. Many older patients take numerous medications that can either mask or mimic signs of shock. Keep in mind the following signs of the normal aging process when managing geriatric patients. The central nervous system often has a delayed response. The cardiovascular system has a variety of changes that result in a decrease in efficiency of the system. On assessment, be alert for high resting heart rates and irregular pulse rates. The respiratory system undergoes significant changes as the elasticity of the lungs and their size and strength decrease. On assessment, be alert for higher respiratory rates, lower tidal volume, and decreased gag reflex. In addition, remember that cervical arthritis may be present and that dentures may cause an airway obstruction. The skin becomes thinner, drier, less elastic, and more frail, thus providing less protection and thermal regulation from cold and hot. The renal system decreases in function and may not respond well to unusual demands such as illness or dehydration. The gastrointestinal system sustains changes in gastric mobility that may lead to slower gastric emptying. Treating a pediatric or geriatric patient in shock is no different than treating any other shock patient. Provide inline spinal stabilization if indicated. If spinal immobilization is not indicated, maintain the patient in a position of comfort. Control life-threatening hemorrhage immediately with direct pressure or tourniquet application when appropriate. Suction as necessary and provide high-flow oxygen via a non-rebreather mask. Maintain body temperature and provide rapid transport. Okay class, let's go over a few review questions. Number 1. The term shock is most accurately defined as A decreased supply of oxygen to the brain, B. Cardiovascular collapse leading to inadequate perfusion, C. Decreased circulation of blood within the venous circulation, D. Decreased function of the respiratory system leading to hypoxia. The correct answer is B. Shock or hyperperfusion refers to the state of collapse and failure of the cardiovascular system or any one of its components. Example, heart, vasculature, blood volume, which leads to inadequate perfusion of the body's cells and tissues. The term shock is most accurately defined as A decreased supply of oxygen to the brain. The rationale for this is it may be a result of inadequate perfusion, but is not the definition for shock. B. The cardiovascular collapse leading to inadequate perfusion. This is the correct answer. C. Decreased circulation of blood within the venous circulation. It may be a result of cardiovascular collapse, but is not the definition of shock. Decreased function of respiratory system leading to hypoxia. Decreased function of respiratory system will lead to hypoxia, which will cause cardiovascular collapse and eventually shock. Review question number 2. Anaphylactic shock is typically associated with urticaria, bradycardia, localized welts, or a severe headache. The correct answer is A. Urticaria, or hives, is typically associated with allergic reactions, mild, moderate, and severe. They are caused by the release of histamines from the immune system. In anaphylactic shock, urticaria is also accompanied by cool, clammy skin, tachycardia, severe respiratory distress, and hypotension. Anaphylactic shock is typically associated with A. Urticaria or hives, which is the correct answer. B. Bradycardia, which is a slow heart rate, is not associated with anaphylactic shock. Tachycardia is. C. Localized welts. Welts are raised, ridged, or bump on the skin caused by a lash from a whip or scratch or similar blow. Not associated with anaphylactic shock. D. A severe heart headache. Altered mental status secondary to hypoxia may be a symptom, but not a headache. Review question 3. Signs of compensated shock include all of the following except a restlessness or anxiety, B. Pale, cool, clammy skin, C. A feeling of impending doom, D. Weak or absent peripheral pulses. Answer is D. In compensated shock, the body is able to maintain perfusion to vital organs of the body via the autonomic nervous system. Signs include pale, cool, clammy skin, restlessness or anxiety, a feeling of impending doom, and tachycardia. When the body's compensatory mechanism fails, the patient's blood pressure falls. Weak or absent peripheral pulses indicate this. The signs of compensated shock include all of the following except A. Restlessness and anxiety indicates compensated shock. Pale, cool, clammy skin also indicates compensated shock. A feeling of impending doom indicates compensated shock and the anxiety associated with. Weak or absent peripheral pulses are not indicators of compensated shock. Review question number 4. When treating a trauma patient who is in shock, lowest priority should be given to A. Spinal protection, B. Thermal management, C. Splinting fractures, D. Notifying the hospital. The correct answer is C. Critical interventions from a trauma patient in shock include spinal precautions, high-flow oxygen or assisted ventilation, thermal management, rapid transport, and early notification of the trauma center. Splinting fractures should not be performed at the scene if the patient is critically injured. It takes too long and only delays transport. When treating trauma patient who is in shock, lowest priority should be given to A. Spinal protection. Stabilization of the spine must take place during the first interaction with the trauma patient. Thermal management. Preventing hypothermia is standard treatment. When treating a trauma patient who is in shock, lowest priority should be given to splinting fractures. Notifying the hospital. Trauma centers need to be notified early during the patient's interaction and transport. Review question 5. Potential causes of cardiogenic shock include all of the following except A. Inadequate heart function, B. Disease of muscle tissue, C. Severe bacterial infection, D. Impaired electrical system. The correct answer is C. Cardiogenic shock is caused by inadequate function of the heart or pump failure. Within certain limits, the heart can adapt to these problems. If too much muscular damage occurs, however, as sometimes happens after a heart attack, the heart can no longer function well. Other causes include disease, injury, and impaired electrical system. Potential causes of cardiogenic shock include all of the following. Inadequate heart function is a cause of cardiogenic shock. Disease of muscle tissue is also a cause of cardiogenic shock. Severe bacterial infection is not a cause of cardiogenic shock. Impaired electrical system is a cause of cardiogenic shock. Review question 6. A 60-year-old woman presents with a BP of 80/60, a pulse rate of 110 beats per minute, molted skin, and a temperature of 103.9 degrees. She is most likely experiencing A. Septic shock, B. Neurogenic shock, C. Profound heart failure, D. Severe viral infection. The correct answer is A. In septic shock, bacterial toxins damage the blood vessel walls, causing them to leak and rendering them unable to constrict. Widespread dilation of vessels in combination with plasma loss through the injured vessel walls results in shock. A high fever commonly accompanies a bacterial infection. The rationale for this: septic shock is the correct answer. Neurogenic shock. Neurogenic shock is an injury to the nervous system and shows bradycardia and hypotension, not fever. Profound heart failure. This is a part of cardiogenic shock, associated with low blood pressure, weak pulse, and cyanotic skin. Severe viral infection. Septic shock is caused by a bacterial infection. Review question 7. A patient with neurogenic shock would be least likely to present with A. Tachypnea, B. Hypotension, C. Tachycardia, D. Altered mentation. The correct answer is C. In neurogenic shock, the nerves that control the sympathetic nervous system are compromised. The nervous system is responsible for secreting the hormones epinephrine and norepinephrine, which increase the patient's heart rate, constrict the peripheral vasculature, and shunt blood to the body's vital organs. Without the release of these hormones, the compensatory effects of tachycardia and peripheral vasoconstriction are absent. Tachypnea. Respirations increase to compensate for the hypoxia associated with shock. Hypotension. Hypotension results from massive vasodilation. Tachycardia. The correct answer. Altered mentation. The patient will present with mental status changes secondary to hypoxia. Review question 8. A 20-year-old man was kicked numerous times in the abdomen during an assault. His abdomen is rigid and tender. His heart rate is 120 beats per minute and his respirations are 30 breaths per minute. You should treat this patient for A. A lacerated liver, B. A ruptured spleen, C. Respiratory failure, or D. Hypovolemic shock. The correct answer is D. The patient may have a liver laceration or ruptured spleen, both of which can cause internal blood loss. However, it is far more important to recognize the patient is in hypovolemic shock and to treat him accordingly. A lacerated liver. You cannot treat a lacerated liver in the field. You can treat the symptoms of hypovolemic shock associated with this injury. The same goes for a ruptured spleen. Respiratory failure. If you treat the hypervolemic shock, then you will treat the respiratory compromise as well. Review question 9. A 33-year-old woman presents with a generalized rash, facial swelling, and hypotension approximately 10 minutes after being stung by a hornet. Her BP is 70/50 and her heart rate is 120 beats per minute. In addition to high flow oxygen, this patient is in most immediate need of A. Epinephrine, B. Rapid transport, C. An antihistamine, D. IV fluids. The correct answer is A. This patient is in anaphylactic shock, a life-threatening overexaggeration of the immune system that results in bronchial constriction and hypotension. After ensuring adequate oxygenation and ventilation, the most important treatment for the patient is epinephrine, which dilates the bronchioles and constricts vasculature, thus improving breathing and blood pressure, respectively. Epinephrine, correct answer. Rapid transport. Rapid transport following high flow oxygen and epinephrine administration. An antihistamine. This is an ALS treatment. IV fluids are also an ALS treatment. Review question 10. All of the following are potential causes of impaired tissue perfusion except A. An increased number of red blood cells, B. Pump failure, C. Low fluid volume, D. Poor vessel function. The correct answer is A. An increased number of red blood cells would allow adequate oxygen and nutrients to be delivered to the cells. An increased number of red blood cells may actually help with tissue perfusion, but is not a potential cause of it. Pump failure is a cause of impaired tissue perfusion. Low fluid volume is a cause of impaired tissue perfusion. Now this is because there's no fluid for the tissue to perfuse. Poor vessel function also is a cause of impaired tissue perfusion. Okay class, this concludes the lecture on Chapter 12. Thank you for listening. If you have any issues or questions, please contact your instructor, and I'll see you in the next chapter.